Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today, we're talking about aneurysm. We're going to talk about the patho, the care before and after, the signs and symptoms, and all that good stuff. So stay tuned. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. I hope you're having a great day. And today we're talking about aneurysms. It's going to be just in generally about aneurysms, signs and symptoms. What's the treatment? What's the surgery? Do you do surgery? And then what do you do before and after the surgery and so forth? So you know this channel is a part of the greater Clinic Review organization. If you're interested in supporting us financially, you can go to clinicreviews.com and sign up for one of our amazing NCLEX online on-demand NCLEX reviews. Mark Klimek, the GOAT himself, teaches those. Mark Klimek, yes, he's still alive, y'all. He's amazing. He's truly amazing. He taught me. I've known him for, 30 years, close to 30 years, maybe 28, 29 years. He's an amazing guy. He's getting close to retirement. So if you want to have a chance to meet him, this is the time to sign up for one of our tutorings or NCLEX reviews. And then we also have a streaming service. So today we're going to talk about aneurysms. And you know that the Blue Book is where we get the information. The Blue Book is a fact book. It's a book of facts that you need to know. It is organized in such a way that it asks the question on the left and the answers on the right. It's not an NCLEX review book. It's just the question and the answer, the question and the answer, the question and the answer. So you can cover up one side and kind of quiz yourself. It's got lots and lots of information, but people often say, what do I need to know for the NCLEX? Well, this is a book that tells you what you need to know for the NCLEX. So what I do is I write questions to go along with the Blue Book so that you can test yourself on the content in the Blue Book. But I don't teach every single thing in the Blue Book. And I write questions sort of to give examples of the things that you're learning in there. So I do still recommend you get the Blue Book. You can get it at Amazon. If you want a hard copy of the book, you can order it as an app from Clinic Reviews. So let's go ahead and get started. A nurse is educating a patient diagnosed with abdominal aortic aneurysm. Which statement by the patient indicates a correct understanding of the condition? So I have worked in vascular surgery in my past life. I worked vascular surgery floor for a long time. You can literally have an aneurysm anywhere. You can have it in the aorta, in the abdomen. You can have a thoracic aortic aneurysm. You can have a cerebral aneurysm. I've seen aneurysms in the popliteal artery behind the knee. So you can literally have an aneurysm anywhere. So the question really is, what is a correct understanding of this is abdominal aortic aneurysm? Let's see what the answers are to see how it pertains to this question. An aneurysm is a ballooning of a weakened area in an artery. An aneurysm is a blood clot that blocks an artery. An aneurysm is a genetic disorder affecting blood clotting. An aneurysm is an infection that narrows my arteries. So this is a pathophysiology question. An aneurysm is actually ballooning of a weakened area of the artery. So what is a risk factor for ballooning out? So you have your nice vessel, then one part gets weakened and it starts to balloon out with the pressure. And the problem is that whenever there's a change in the diameter of the vessel, what happens is it goes through and it swirls around before it goes out. So what happens is you actually develop clots along the edges of that vessel, and they can throw a clot. So that's a risk factor. There's a risk factor that the aneurysm can rupture. So that's a risk factor. So what causes this weakening? I'll tell you the number one risk factor is genetics. So there's a strong genetic component. If someone has an aneurysm, all of their first degree relatives should be tested for an aneurysm. And the testing, the most inexpensive non-invasive testing is just an ultrasound. So they can do that as sort of as an introduction, initial testing for an aneurysm. The second thing is hypertension. That's a big risk factor. And then really the typical ones, smoking is a risk factor. Diabetes could be a risk factor. Obesity could be a risk factor. Those are lower on the list. I'd say number one is genetics. Number two is hypertension. Probably number three. If you have those two things and you smoke along with it, then you're like really, really at high risk. Patient with a thoracic aneurysm, so that's up here. So it's still the aorta, but it's in the thoracic area. So, the aorta kind of exits the heart and then goes down. So you can have an abdominal aortic aneurysm. A thoracic aortic aneurysm is being assessed by the nurse, which symptom is most likely to be reported. lower back pain, increased urination, headache and dizziness, or difficulty swallowing. So this is an example where you do have to pay attention to the location. For abdominal aortic aneurysm, most often it's asymptomatic, but if it is symptomatic, it's usually low back pain. So abdominal aortic aneurysm is low back pain. I don't know of any that have a symptom of increased urination. I would think cerebral aneurysm could be headache and dizziness. That could be that one. And then difficulty swallowing. If you think about a thoracic aneurysm and you have an outpouching, it could be pressing against the esophagus. So that could be difficulty swallowing. So from a location perspective, that's the only one that makes any sense. How often they have difficulty swallowing, I don't know. Aneurysms are sort of known as asymptomatic, but if they do ask you a question like this, just think, okay, location. Where would the symptoms be associated with this specific aneurysm? A nurse or the nurse is caring for a patient with an unruptured cerebral aneurysm. Which intervention is most important to include in the care plan? So we don't know where the cerebral aneurysm is. It's somewhere in the head area, in the brain, I guess. Encourage isometric exercises. Isometric exercises involve pushing, like lifting, pushing. And it seems like that would increase intracranial pressure. So when I'm pushing or lifting, I'm going to increase intracranial pressure. I don't think I want to do that when they have a cerebral aneurysm. Monitor neurologic status every hour. Well, that makes sense. I mean, if it ruptures, they're going to definitely have a change in level of consciousness and I think some neural changes. So that seems important. Administer anticoagulant medications. Anticoagulant medications, I suppose we could, but I don't know. That might help prevent some of those clots in there from traveling, but I'm not sure that I want to give an anticoagulant medication because if it does rupture or if it starts to leak, then it's just really going to bleed endlessly. So that doesn't seem like a good idea. Provide a high sodium diet. So high sodium increases water retention, which could increase blood pressure, which hypertension is a risk factor for aneurysm. So that doesn't seem like a good idea. So the only one that makes any sense at all is monitor neurologic status every hour. And you may say, well, Sharon, I could have gotten that answer without going through all that stuff you just went through to explain every answer. But that's the part of the point of doing these with you is I want you to learn how to think. So if you didn't know the right answer, how do you get to it? How do you think through it? How do you use clinical reasoning? Y'all, NCLEX is a straight up clinical reasoning test. You should not expect to know every answer when you read it. You read the question, you think through it, you use clinical reasoning and common sense, and you determine the answer. Plus testing strategies, which I teach in a lot of the videos as well. A patient scheduled for surgical repair of an abdominal aortic aneurysm asks why blood pressure control is so important before surgery. What is the nurse's best response? Maintaining low blood pressure reduces the risk of bleeding during surgery. I don't know that that's true. I'm not going to automatically cross it off, but that doesn't seem like necessarily true for it to be true during surgery. Blood pressure helps prevent rupture before the operation. Well, that would be true. High blood pressure can lead to kidney failure after surgery. Wait, what's the question? Ask why blood pressure control is so important before surgery. Well, C doesn't make any sense with the question. Controlling blood pressure will eliminate the need for surgery. Well, that's not true. The only one that makes any sense, just using my common sense and clinical reasoning, is B. That's the only one. We do keep blood pressure lower before, and it depends on afterwards. If they cut into the vessel, like if they do an open abdominal or if they do an open aortic aneurysm repair where they actually cut into the vessel and they repair it that way, like they put a patch in, then you're going to want to keep blood pressure pretty low because you don't want those sutures to rupture afterwards. Like for 24 hours, you keep it pretty low. But if they do an endoscopic repair is where they go in either through the brachial or the femoral artery, and they just thread up through into the aorta or wherever it's at, and they release a stent. So it's like a little metal mesh thing, and they release a stent that just helps to strengthen the wall of the vessel. So if they just do that and they release a stent, then keeping blood pressure low is not as big of a deal afterwards. The risk with releasing a stent is that it could shift after surgery. So for the first 24 to 48 hours, after releasing that stent, you're really watching for pain, kind of severe, like tearing pain after that. But other than that, it's a pretty comparatively, it's much lower risk than open repair of an aneurysm. Open repair of an aneurysm, they're in the hospital for several days. They have an NG tube. I mean, it's a big, big surgery. So I'd say most aneurysm repairs now are considered endoscopic. Endoscopic, whenever you hear about an endoscopic surgical repair, endoscopic always means from within the vein, from within the vessel. It means they didn't cut into them. In preparing a teaching plan for a patient being discharged after surgical repair of an aortic aneurysm, which instruction is most important for the nurse to include? So they're going home. We don't know which type of surgery they had. Avoid lifting objects heavier than 15 pounds for 6 weeks. Heavier than 15 pounds for which instruction is most important for the nurse to include? Okay, avoid lifting. Definitely, you don't want to lift anything heavier than 15 pounds. So 6 weeks is a good standard of care, or standard for how long post-op restrictions last. Like if you don't know for sure how long post-op restrictions last, then 6 weeks is your best option. 15 pounds seems a little high. I probably would go like 5 pounds, but okay. We'll leave it as a possibility. You can resume sexual activity in 2 weeks. Usually resume sexual activity in 6 weeks. So 6 weeks, sort of that standard time. Driving is permitted as soon as you feel ready. That's not true. Driving is usually restricted for 6 weeks. High intensity exercise will help your recovery. No, you don't have to be on bed rest, but we need to let you heal up. So high intensity exercise is not appropriate. So the only one, B and C and D are all wrong. So I'm going to go with A because they definitely don't want to lift objects heavier than 15 pounds for 6 weeks. I probably would have gone more like 5 pounds, but fine. A patient with a known abdominal aortic aneurysm presents with a sudden severe abdominal and back pain and signs of shock. What is the nurse's immediate priority action? So priority means if I can only do one thing, what's the one thing I have to do? Well, they've got an aneurysm. They have the signs and symptoms of a ruptured or leaking aneurysm, which is the abdominal and back pain, and shock, which means they had to have ruptured. I mean, they're going into shock. Administer prescribed analgesics? No. Prepare the patient for immediate surgery? Maybe. Obtain vital signs and notify the physician? Absolutely. Start an infusion of normal saline. I'm sure I will do that. I'm sure I will do D, and I will probably do B, but I have to obtain vital signs and notify the physician. I have to do that. Which medication would the nurse expect to be prescribed to a patient with an unruptured cerebral aneurysm to prevent complications? Unruptured. Okay, so we don't want it to rupture. So we don't want them to smoke. We got to maintain their blood pressure. Cerebral aneurysm, we probably don't want a lot of increased intracranial pressure, so maybe a stool softener. So those are the things I think of right off the bat when I think about for unruptured, we want to prevent complications. Naproxen sodium. Which medication? Which medication? Naproxen sodium. Well, naproxen sodium is for pain. That's not going to do anything for cerebral aneurysm. Antiplatelet agents. Well, that prevents clots. Preventing clotting doesn't do anything to prevent complications. Well, I suppose it could prevent a complication if you throw a clot from those clots that are probably forming in there. So that's a possibility, maybe. Diuretics. Diuretics can lower blood pressure, but that doesn't seem like that would be the treatment for this. Calcium channel blockers. Calcium channel blockers do lower blood pressure. So managing blood pressure is really important for someone who has an unruptured aneurysm, any aneurysm, but isn't going to be treated surgically. And they're not all treated surgically. They usually monitor them for a while. Like they'll come in maybe say every 6 months for an ultrasound, and they'll monitor the size. And then they'll say, hey, if you notice this or this, let us know. We can bring you in. But until I think it's at least 4 centimeters, they don't usually do surgery. So they could have an unruptured cerebral aneurysm. So I want to keep their blood pressure down. The complication I'm thinking of is rupture. And the thing that's going to prevent the rupture is the calcium channel blockers, because those are for blood pressure. So that's what I'm going to go with. Which patient statement indicates a need for additional teaching about managing an unruptured aneurysm conservatively? Additional teaching. So I'm looking for the false statement. So I prefer to say further teaching, because that further teaching means false, but I'm going to go, okay, so which is the false statement about managing an unruptured aneurysm? I will need to have regular imaging tests to monitor the aneurysm site. That's true. Maintaining good blood pressure control is important. That's true. I should increase my intake of green leafy vegetables for vitamin K. I don't see why. I'm going to put a question mark next to it. Smoking cessation is critical for my condition. That's true. So I know A, B, and D are true. C doesn't make a lot of sense to me. So green leafy vegetables, if you take more green leafy vegetables, you're going to be less likely to clot. So vitamin K is the antidote for Coumadin. So Coumadin makes you clot more slowly. So if I take vitamin K, it means I clot more quickly. Is there any reason I would want to clot more quickly? Well, I suppose if it ruptured, I'd like to clot more quickly, but it's not going to do anything to manage the aneurysm itself. And I know A, B, and D are all true statements as to the management of aneurysm, so I'm going to have to go with C. I'm going to have to go with that. That doesn't seem like a typical teaching for this. During the post-op period following an endovascular aneurysm repair, remember I told you endovascular means they go in through the vessel, they don't cut into them. Which assessment finding would require immediate intervention by the nurse during the post-op period? So when I think of that, I think of, I want to make sure that stent isn't going to move, because if it moves, it can cause some tearing and some bleeding and some really significant pain. So that's my first thought. Let's see what the options are. Wait a minute. Which assessment finding would require immediate intervention? So I'm looking for the unexpected finding. Warmth and redness at the groin insertion site. Warmth and redness. This is in the immediate post-op period. That seems warmth and redness. That seems reasonable. I mean, it can't be infection yet, because infection doesn't happen that quickly. So warmth and redness to me just indicates some irritation. So what am I going to do about that right now? I'm not going to do anything about that. Urine output of 20 mils over 2 hours. Well, that's low urine output. So that's unexpected. Blood pressure of 118 over 76. That's expected. Capillary refill of less than 2 seconds. That's expected. So urine output is low, so that's unexpected in the immediate post-op period. I expect them to have normal urine output. It should be at least 30 mils an hour, so they should have had at least 60 mils in 2 hours. Which of the following is the most significant risk factor for the development of an aneurysm that the nurse should assess for? Significant risk factor: smoking, high cholesterol, sedentary lifestyle, or obesity. Sedentary lifestyle, I'm going to take off the list. I'm going to say no. That's not a significant risk factor. Could high cholesterol, does that do anything to weaken the vessel wall? I don't know that high cholesterol does anything specific to weaken the vessel wall. Obesity, I don't, in combination with other things, I know it could be a risk factor, but I don't know of a specific factor. Whereas I know smoking, y'all, I put this in here for a reason. If a risk, they're asking you about risk factors, and one of the options is smoking, I would say 98 times out of 100, the right answer is smoking as a risk factor. Very rarely do I not pick smoking. So I'm just showing you that if they're asking about risk factors, when one of them is smoking, look at it. And unless you know for sure it's not a risk factor, pick smoking. A patient with an abdominal aortic aneurysm is prescribed atenolol. What is the primary reason for administering this medication? Okay, Alol drugs, LOL. These are beta blockers. Why do we give beta blockers? To lower cholesterol? No, that doesn't lower cholesterol. To prevent arrhythmias? Yes, it could prevent tachycardia, so it could do that. To reduce myocardial oxygen demand? Well, it definitely does that. That's why we give it after my heart attack. To decrease heart rate and blood pressure. Okay, well, I know it does B, C, and D. So let me reread the question. A patient with abdominal aortic aneurysm prescribed atenolol. What is the primary reason for administering this medication? Okay. So when you get a question like this, like they tell you the patient's diagnosis, and then they give you the drug, and they say, why are they taking this? You have to say to yourself, well, what is this drug going to do that's going to treat this specific problem? And this specific problem, an aneurysm, is not an arrhythmia, and it's not a heart attack. But we do know that high blood pressure can exacerbate aneurysms. And so I'm going to have to pick D, even though I know atenolol can do B and C. That's not why we're giving it. We're giving it to decrease blood pressure, and it does decrease heart rate as well. In the event of suspected ruptured abdominal aortic aneurysm, okay, it's ruptured, so that's an emergency. Which diagnostic test would be most appropriate for immediate evaluation? So we want something that's easy and quick. Easy and quick. MRI, that's not easy and quick. CT without contrast, well, that's easier and quicker than MRI. So maybe. Abdominal ultrasound. Aha, there's my easy and quick option. Chest x-ray. Chest x-ray doesn't tell me about the abdomen. So the easiest and quickest one is an abdominal ultrasound. CT, MRI, those are fine if you're not looking for easy and quick. But easy and quick is an abdominal ultrasound. Which instruction is most important for the nurse to include when teaching a patient about signs of a leaking abdominal aortic aneurysm? So it hasn't ruptured completely, but it is leaking. Seek immediate help if you experience sudden back or abdominal pain. Watch for increased urination and thirst. Report any episodes of constipation. Notify your doctor if you have a persistent cough. So I'm trying to get them to tell, oh, they don't have a leaking aneurysm. I'm trying to teach them to watch for signs and symptoms of it. Okay, I had to go back and reread the question. Well, increased urination isn't a sign. Constipation is not a sign. Coughing is not a sign if you have back pain or abdominal pain, specifically if it's sudden. That tells you, uh-oh, that's not good. A nurse is caring for a patient with an unstable abdominal aortic aneurysm. Which nursing intervention is most important to include in the plan of care? Unstable abdominal aortic aneurysm, which means it's probably getting bigger. We've probably brought them in to watch them, and we're probably going to do surgery. Encourage ambulation 3 times a day. That doesn't seem like a good idea for an unstable patient. Maintain strict bed rest. That seems like a pretty good idea. Assist with coughing and deep breathing. Absolutely not, y'all. Somebody's got unstable aneurysm. Don't be increasing pressure. Like coughing and deep breathing increases pressure here. It increases intrathoracic pressure, increases abdominal pressure. No. Provide a high fiber diet to prevent constipation. Well, I would want to do that. That seems like a good idea. All right. So what's most important? Well, I know A is out and I know C is out. Okay. So which is more important? Maintaining strict bed. I'm going to maintain strict bed rest, but not do a high fiber diet. I'm going to do a high fiber diet, but not maintain strict bed. Y'all, I have to maintain strict bed rest. That's standard of care for an unstable aneurysm. That's standard of care. Okay. Well, I hope that was helpful to you. I don't know if you'll have this on NCLEX, but there is what's called a pseudoaneurysm, PSEUDO, pseudoaneurysm. A pseudoaneurysm it looks just like an aneurysm, and it's just as much of a risk to rupture as aneurysm, but it's not caused by a weakening of the vessel. So a pseudoaneurysm, like a fake aneurysm, is where you get a tear on the inside lining of the vessel. It's not a weakening, but there's a damage somehow, a tearing. Could happen during like a motor vehicle accident, or maybe someone who has a lot of IV drug use. They could cause damage to the inside of their vessel. And so you get this tear. And so you start to get blood going into the vessel in between the layers. And so it's like it starts to balloon out because it's filling in between the inner and the outer layer. And so it happens a lot more quickly. It requires a little bit more, a little faster intervention. We don't like watch them. Okay. Someone has a pseudoaneurysm. We're like, we got to repair that. So that's just slightly the pathophysiology that is just slightly different than a regular aneurysm. All right. Well, I hope you enjoyed this. I hope you have a great rest of your day, and I'll see you later. Bye.